It's an honor for me to share this case with you all here today. This was about a 2.5 hour CTO case, so I'm going to do my best to condense this to 5 minutes. I'm not usually a fast talker, but I'll do my best here. I don't have any financial disclosures. This is a 75-year-old gentleman who was referred to me by a colleague in my community. He'd been experiencing progressively worsening shortness of breath, which was always thought to be his angina equivalent. His initial workup led to an echo that showed his ejection fraction had dropped from 47% down to 30 to 35%. His workup led to a cardiac catheterization that suggested left main and right coronary CTOs, a patent limit LAD, chronically occluded vein graft to RCA, chronically occluded vein graft to diagonal, and a critically stenosed vein graft to an obtuse marginal. Because of the degenerated appearance of the vein graft, the referring doctor did not believe that the vein graft was salvageable, so he was referred to me to consider CTO PCI of the native vessel. Although the diagnostic cath was performed in October of 23, about 2 weeks thereafter, he was diagnosed with subsegmental pulmonary emboli, and the patient was advised to complete 3 months of uninterrupted anticoagulation before going any additional invasive procedures that would interrupt his anticoagulation. I met him about a month or two after in the office, after the diagnostic procedure, and we performed a cardiac MRI in the meantime, which showed that the right coronary artery was non-viable, but all other territories of the heart are viable. The ejection fraction was 32% on that. He's on reasonable medications, except that he's allergic to statins. His bypass surgery was back in 2004. Exam was unremarkable. These are a few pictures from the referring doctor's angiogram. This is the right coronary artery CTO, which, as mentioned, was non-viable by MRI. This is the left coronary injection. This is the old occluded vein graft to a diagonal artery, which has been known to be occluded for many years. This is the stump of the vein graft to the right coronary artery. This is the vein graft to the obtuse marginal, which has a critical osteal stenosis. And again, the referring doctor didn't even try to fix it. He just thought this wasn't salvageable. This is the lima to the LAD. Here's a couple of representative images of the cardiac MRI. This is a two-chamber view. The calculated ejection fraction was 32%. This was a sample image of the delayed contrast imaging, which was read out as a non-viable right coronary artery. So when I brought the patient back for the intervention about 3 to 4 months after the initial procedure, this is what the left main coronary artery looked like, and for better or for worse, this is what the vein graft to the obtuse marginal now looked like. And because of the uncertain anatomy, working with an antegrade approach, I decided this was a primary retrograde case, and my only real good, well, not good, but my only retrograde option was to use the old occluded vein graft to that obtuse marginal as my retrograde channel. So I did this by penetrating the proximal cap of the vein graft using a warrior wire, which I initially advanced about 1 centimeter into the graft. I chased that with a Turnpike LP microcatheter, and then worked down to a Mongo wire, which I was able to drill all the way through the body of the graft towards the obtuse marginal. I then tried to chase that with my Turnpike LP microcatheter. I could spin it to this location here, but could not spin it any further despite significant amount of time and aggressive spinning of the catheter. I then took out the Turnpike LP microcatheter and just did a balloon inflation with a 2030 balloon as far as I could push it. And then I switched out to a Mamba Flex microcatheter, which I was able to spin around that turn and down the body of the graft towards the target vessel. I then took out my Mongo wire and formed a selective angiogram through my microcatheter to better understand the distal anatomy. I then reinserted my Mongo wire, but directed it up towards the distal cap of the occlusion in that obtuse marginal, and then performed this angiogram to better understand my anatomy. I tried to cross retrograde, but probably because of the angle in the graft itself and the second angle where the graft attaches to the obtuse margin, I just didn't have enough backup to cross retrograde. So then I just switched to an antegrade technique using my warrior wire and aiming it towards my retrograde Mongo wire. Once I got wire overlap, I chased that with a turnpike spiral microcatheter, and after that crossed the body of the CTO, I was able to switch out for a workhorse Xi'an blue wire, which you see here going down the obtuse marginal. Angioplasty and stenting was then performed using standard techniques, and we got a good final result. In conclusion, the patient was discharged the following day without complication, continued to report resolution of his angio equivalent symptoms at 3 months. We did a follow-up echo about 3 months to decide if he needs a defibrillator, but his EF actually came up to 50%. In conclusion, old occluded vein grafts can sometimes be used as a retrograde channel to solve complex CTO cases. A retrograde wire position just beyond the distal cap of a CTO can sometimes be used to facilitate antegrade wiring using the just marker technique. Thanks.